Hello, I'm Steve Miller, an EP nurse and the trainer for the Esosure esophageal retractor. The Esosure is a temperature-programmed nitinol stylet. What that means is at room temperature, it's set up to be fairly flexible in order to be able to make the curve at the back of the throat as it slides down the lumen of an 18 French or 16 French Salem sump OG tube. As it comes to body temperature, it's going to go from a straighter position or angle or shape, the straighter shape, to a more curved shape, and the wire will get stiffer. So it'll go looking from like this to looking like this. I don't know if you'll be able to see it in the water, but here it is at room temperature. And this is what happens at body temperature. And it happens very quickly. It happens in like about 2 seconds as it goes into the body inside an OG tube. So this is the Esosure, and it is used to move the esophagus. So the procedure for moving the Esosure is described very completely in the training sheet that's in each box. Okay? The training sheet is just 2 quick pages. The front page is the basic information, and then in back there's some more pictures and some additional information. The equipment that you need is very simple. A 16 or 18 gauge or 18 French Salem sump OG tube, just like this. Every hospital has hundreds of these. 2 to 3 20cc syringes full of water or IV fluid. We just want it at room temperature. A packet of tube lube, or OG tube lube. It comes with each Esosure. It will be inside the box, taped to the packaging for the Esosure. Now the OG tube lube is for lubricating the lumen of the OG tube, not the outside, but the lumen, because we need good lubricant on the lumen in order to slide the Esosure down inside of it. Now we call it OG tube lube because I was told that olive oil didn't sound very medical. But that's what it is. It's just olive oil. So we know it's safe and it works better than anything we could find in the hospital. Okay? Then there's the Esosure itself. It comes like this. This is what the box looks like. There's one in each box. Okay? The last thing is 99% of the hospitals I've been to use a temperature probe, an esophageal temperature probe. Now, out of those, probably 75% or more use what's called an acoustoscope temperature probe. I want you to check with anesthesia to see what type they're using. Most of them use an 18 French acoustoscope. These should not be used in the EP lab. The reason for that is there's 2 layers of air and 2 layers of plastic around the thermistor. And what they do is they insulate the thermistor from detecting changes in temperature, which is not what we want in the EP lab. It's okay in a normal OR procedure, but not for us. What is much, much better, actually 4 times faster, is a simple 9 French esophageal temperature probe. The same company that makes this probably also makes a model that looks like this. This is a DeRoyal. Smith's Medical also makes both of these models. Okay? But this is the one that should be used in the EP lab. When you're using this smaller diameter temperature probe, have anesthesia use a 4 millimeter pediatric endotracheal tube as an introducer, because these are a little bit softer and floppier, especially at body temperature. Using a PZT tube as an introducer, inserted orally down into the esophagus, and then lubricating the outside of this, just makes it slide down the throat so much easier. It makes it so we can reposition it much better, and it just makes for a far superior way of finding out what temperature is going on in the esophagus. Okay. So that's the equipment that we need. Now the prep is the patient needs to be endotracheal intubated. An LMA I don't believe will work because the balloon in the LMA fills up the airway, and I don't think there's going to be room for the Esosure to slide down the OG tube safely, so I would not recommend an LMA be used. The second thing is lubricate the lumen of the OG tube. Oh, where did I put that? There it is. The easiest way to do that is have anesthesia hook up the OG tube to suction, take your tube lube packet, rip it off, and if you rip it at an angle, that will give you a bigger hole, and then put the end of the OG tube into the packet and suction it through the lumen of the OG tube. Take it out, just kind of give it a couple seconds to suck through any remaining, and that way you lubricate the lumen and you don't have an oily mess on the outside. So that works very nicely. Okay? Now, when they put down the OG tube, we want them to use extra lubricant on the outside. Not only on the OG tube, but also on the temperature probe, because we'll be sliding this in and out of the mouth to position the curve during the procedure. And if they don't use a lot of lubricant, it has a tendency to get stuck and it can cause problems. Extra lubricant just works very easily. Okay? Now, if you use contrast, either radiographic contrast or ultrasound contrast, it needs to be injected down the OG tube after you first position the OG tube in the stomach and then retract the OG tube behind the heart. If you just put the OG tube down behind the heart and then inject it, it could sneak beside the endotracheal tube, go down the trachea, go down the right inferior bronchial, and look like it is in the esophagus behind the heart and be in the lungs. And contrast is very pulmonary toxic, so start off with it in the stomach, pull it back behind the heart, inject. Just a syringe with 20 cc's will work fine. The syringe hooks on to the end of the connector for the OG tube. And as you're injecting it, retract. This one is old and worn, so it didn't stick very well. As you're injecting it, watch it under fluoro. If you inject it and the contrast flows down into the stomach quickly, then pull the OG tube back a little bit higher and then inject a little bit more. Go slowly. If the contrast tends to flow up, then insert the OG tube down a little further, because you just need to fill the esophagus behind the heart. Okay? Then after you fill it, just reinsert the OG tube back down into the stomach and you're ready to go. Okay, so that's the prep. Now the procedure. There's 6 quick steps. I use the mnemonic BOCA RT as a reminder. B-O-C-A, which is mouth in Spanish, RT. Okay, the first step is a bolus of anesthesia. Now, if you're putting the Esosure down right after the patient is intubated, before you even get vascular access, the patient is going to be paralyzed from the paralytics given by anesthesia, so you're not going to need to give any extra anesthesia and just slide it down afterwards. But if your procedure is to put the Esosure down later in the case, you want to have anesthesia give some extra anesthetics. The reason for that is the patient gets more awake, anesthesia gives sedatives, they get more sleep, they get more awake, and that's the normal flow through the procedure. We want the patient to be completely out. We don't want to elicit a gag reflex as the stylet goes down, have the patient start coughing, bucking, bouncing around, changing the 3D map, and just making a mess of things. So have anesthesia, give an extra bolus of propofol, narcotics, whatever they're given, because we want the patient completely out. The next thing, number 2, is open and align the airway. If you're the EP staff who's going to be putting down the Esosure, have your anesthesia person come up and do a nice 2-handed head tilt jaw thrust. Tell them that you want the airway in the same position as when they're intubating the patient. We want it as straight as possible. Some anesthesia people will just try and put a little finger under the jaw. Ask them to please do a nice 2-handed head tilt jaw thrust so we can have a nice aligned airway. It really makes it go quicker and easier and less traumatic. Number 3 is cool the OG tube. That's what our fluid was for. Hook the end of the syringe to the connector, and over about 5 to 10 seconds, slowly inject the OG tube. As I told you, the Esosure forms its curve at body temperature. So we want to keep it in its soft, straight shape as long as possible. By cooling the OG tube, it will keep the Esosure soft for about 10 to 12 seconds. Oh, I forgot something. Before we inject that down, I always forget to tell people this. Pull out the Esosure and hold it in the same hand as the OG tube. So we'll go back and do that again. So you're holding the Esosure, you're holding the OG tube in one hand, pull it out straight from the mouth, hook up the syringe with the cool fluid, inject it. While they're holding the airway open, pull it out, take the Esosure, inject it as quickly as possible. And when you're inserting it, insert it about 2 inches at a time as quickly as you can. Now as it goes down into the body, it'll start to form its shape slowly, and the physician will tell you which side he wants initial deflection. Say, if it's a first-time procedure, most physicians do their left upper and their left pulmonary veins first, so we'll want to deflect to the right. As we put this one down, the curve went to the right very nicely, so all we would do would be to kind of slide it up and down, give it a little wiggle. Also, you can have anesthesia hold the patient's breath at the end of exhalation. What that does is to reduce the volume of air in the lung and makes less pressure against the Esosure as we're trying to slide the esophagus in between the lung and the spine. That's where the esophagus goes most of the time. Now, if we're putting it down, and say it's a repeat procedure and the doctor wants the curve to the left, if we put it down and the curve is to the right, we're going to need to rotate it over. So, take the handle and just rotate the handle about 3 full times, and then gradually pull back the Esosure, and as you pull it back, the tension in that will cause the stylet to flip over to the other side, and then slide it down into position behind the left atrium with the curve on the left. Okay? Now, if we need to go back to the other side, just rotate it again. Rotate it 3 times, gradually pull it back. When it flops over, slide it back down. Now there are 3 positions for the Esosure. One is with the primary curve to the right. The easiest way to go from right to left is just to advance it. And if we slide the Esosure down, you'll see the primary curve, the apex of the primary curve as it reaches the diaphragm. The secondary curve slides down, and now it's pushing over to the left. Okay? So position 1 is with the primary curve to the right. Position 2 is with the secondary curve to the left. Secondary curve is a little bit smaller. So if you need to, retract the Esosure back above the diaphragm and then do the rotation again. Rotate it, pull it back till it flops over, slide it back down so you have the primary curve to the right. Okay. The last thing you do is once you get your Esosure curve in the position that you want, retract your temperature probe. Now when they put the temperature probe down, we want them to put the temperature probe in the stomach as well. And then when we get the Esosure curve where we want it, then we retract the temperature probe, and the majority of the time the smaller diameter temperature probes will pull so that they're on the inside of the curve towards the edge of the esophagus closest to the ablation catheter. This is right where we want it, because right now when you put a temperature probe in, you don't know which side of the esophagus it's on unless you're using contrast. So this helps us to better position the temperature probe. So that's the last thing that you do. Okay? And that is the Esosure. Thank you.